Dr. Rakesh Gupta would have gotten engaged somewhere. Nevertheless, I am going to talk to you about the left ventricular systolic function assessment and going to be focused on the wall motion abnormality assessment. So, mainly, the systolic function predominantly is assessed in regional fashion or global fashion. And the reason why it happens so is the commonest reason for the heart weakness is coronary artery disease. And suppose if you have a lesion here, if you can follow this marker, the area subtended with this coronary artery would have ischemia. And there is an ischemic cascade we all know would happen thereafter. First is the flow heterogeneity, then there would be metabolic alterations, diastolic dysfunction, and then it would be the dyssynergy, that means wall motion abnormality, before the symptoms would arise. So if you look at this particular four-chamber view, you can imagine the mitral valve. You can see the basal segments towards the mitral valve are contracting really well, but if you look at the apical segments, they are hardly contracting. Rather, they are going out of the view in during the contractility phase. So this is certain areas of the ventricle not contracting at all, rather going outwards instead of coming inwards. And there are certain areas we are decently contracting. So this situation when there are certain areas not contracting, vis-a-vis certain areas which are contracting, we call them various segmental wall motion anomalies. Problem with this is that most of the times, I mean, invariably, whenever such thing happens that there are certain areas of the left ventricle which are not contracting and certain areas which are contracting well, this is linked to coronary artery disease or ischemia until and unless proved otherwise. Yes, there are certain situations such as pachymyocarditis or sarcoidosis, for example, where you can have certain areas not contracting, but that is not linked to a coronary artery disease. But I'll explain how it can be extrapolated and calculated whether it is coronary artery disease related or not. So whenever we do the segmental wall motion analysis, we have to rank each and every segment as a part of the ventricle. And I'm going to be focusing on the left ventricle itself. What happens is the whole length of the left ventricle is divided into three parts: the basal third, middle third, and apical third. And each circumference is further divided into six or four parts. On the basis of that, we may have a 16 segment scoring system of the left ventricle, 17 segment or 18 segment. But as far as echocardiogram is concerned, we are focused still on the 16 segment scoring system because each of these segments are almost equivalent in the amount of volume of myocardial muscle unless there is a large infarction, and we'll talk about it. So if you look at this cartoon out in the center, which is a short axis view, this short axis view, we can imagine these are the papillary muscles, the posterior inferior, and on the other side is the lateral papillary muscle, the anterolateral. And there are attachments of the right ventricle, the anterior portion as well as the posterior portion. So if you look at the transposition of this short axis view into the other bread and butter views, the long axis view, when we are placing the transducer anteriorly and cutting the ventricle in this particular direction, the beam is going to cross through the anterior portion of the interventricular septum, we call as anterior septum, and the posterior wall, which is between the origin of papillary muscle. So the posterior wall would not give rise to the papillary muscle, and we should not see the origin of papillary muscle in the parasternal long axis view. This is how it would appear. We would have the basal and the mid anterior septum and the basal and the mid posterior wall. Mind it, the apex is devoid of any anterior septum and posterior wall, and that is why we should not rank any segment in the past and long axis view in terms of the apical segments. Thereafter, we move towards the four-chamber view, and we all know how to obtain a four-chamber view. And here is the ventricle which is cut in this particular direction, which would mean there would be a portion of the right ventricular free wall. This is the right ventricular free wall here. This would be the posterior part of the septum. We commonly call it septum because it would have a basal, mid, and apical septum. And mind it, at the apex, we do not have anterior septum. That is why this is collectively called as septum rather than the posterior septum. And the lateral wall on the other side, this is the lateral wall, which gives rise to the, in the middle segment, the papillary muscle, the anterior lateral papillary muscle. So we would have the basal lateral, mid lateral, and apical lateral, basal septum, mid septum, and apical septum in the four-chamber view. Thereafter, when we twist the transducer 60 degrees, what we do is we lose the right ventricle completely. This right ventricle would not be available in the two-chamber view. And what would have here is the inferior wall. This is the inferior wall with it giving rise to the posterior inferior papillary muscle. So there would be basal inferior, mid inferior, where the papillary muscle arises, and the apical inferior. On the other side, there would be basal anterior, mid anterior, and apical anterior. You can see again no papillary muscle there. So in totality, where we would have is 1,
మీరు
2,
ఎంఆర్ఐ
3,
స్కాన్ చేయించుకోండి
4, 5, 6, 7, 8,
వెన్నులో
9, 10,
ఈ
11,
వెన్నుపూస
12,
ఉంది కదా
13,
ఆ
14,
వెన్నుపూసలో
15,
ఎక్కడ
and 16.
నొక్కుతుంది నరం
16 seconds.
అదే ప్రాబ్లం
So, can I request everybody to
Dr.
put
Ravi,
themselves
please
on
mute
mute?
కాదమ్మా
yourself.
ఇది కొత్తపేట లలిత్ చాలా పెద్ద
Hello.
మిషన్ ఓకే
Can I request
సో
everybody to
అది
put
ఓన్లీ
themselves
కొన్ని
on mute?
ప్లేసెస్ కొన్ని చోట్లే ఉంటుంది
Yeah, thank you. Um, so thereafter, importance is that if we have detected wall motion abnormalities and particularly ranked them as segments of the left ventricle, we have to now learn to associate them with coronary distribution. What I'm going to describe now is the common arterial distribution territories. So, for example, the first one is the LAD. The left anterior descending artery is an artery which runs from the anterior AV groove all the way into the interventricular groove to the apex, and then almost completely winds around the apex, right? So what areas it would supply is obviously through the course of the LAD, the septal arteries would be supplying anterior portion of the septum, and the diagonal branches would be supplying the anterior wall. So there would be the first septal and the basal segments, the second or third septums supplying the middle and the apical septum. And at the apex, we know it is the terminal portion of the LAD which is supplying. So in a way, what is happening is the LED is supplying almost 50 to 55% of the myocardium. Basal anterior, mid anterior, apical inferior, apical lateral, apical septum, and also the basal and mid anterior septum. So we can see the LED supplying almost half or more of the left ventricle. Now let's look at the course of the circumflex. We know the circumflex winds around the AV groove from anterior to the posterior side, and while it is on the way, it gives rises to obtuse marginal branches. The proximal areas, the basal and mid lateral, and the posterior, which is a distal, more distal circumflex supplied by the mid and basal posterior is supplied by the distal portion of the circumflex, which is the OM2s and OM3s. If you look at the PDA, it runs in the posterior interventricular groove from base to the apex, falling usually short of the apex, and usually supplied by the right coronary artery or whichever artery is dominant, the circumflex or the right. So the PDA supplies the basal and mid septum area, this area, and the basal and mid inferior is supplied by posterior left ventricular branches of the right coronary artery. So if I put all three arteries in a perspective, then the four-chamber view would have representation of all three arteries. The apical segments, apical septum and lateral is supplied by LAD. Mid and basal inferior is supplied by, the septum is supplied by the RCA or PDA, and the mid and basal lateral is supplied by the circumflex. So usually the four-chamber view is a representation of all three coronary arteries. Now, if we look at and place the three circular short axis view, this is at the level of mitral valve, this is at the level of papillary muscle, and this is at the apex, in one on top of each other and draw a concentric circle, as I showed you earlier, this would become a bull's eye plot. So, and the bullseye plot, as I said, the basal segments would be supplied by various segments, various coronary arteries. The basal segments are anterior, lateral, posterior, inferior, septum, and anterior septum, six segments. The mid portion is also the same, anterior, lateral, posterior, inferior septum, and anterior septum. And the apex has only four, as I had described earlier. What happens now is the LED is running in the anterior interventricular groove from the base to the apex and winding round. So all the areas through the course is being supplied by the LED, and this is a bullseye representation of the LED territory. The circumflex goes into the AV groove and supplies OM1, OM2, and OM3, and this is how it would be supplying the various segments. The septum is supplied, the posterior septum or basal and mid, not the posterior, but septum is supplied by the PDA artery from the RCA usually, and the PLB supplying the inferior. So this is how we can have a correlation of various segments to the coronary. The third rule for the coronary distribution of the segmental distribution of the coronaries is if you have a lesion in the proximal LAD, the distal most portion is the first to suffer, and in that proper order. So if there is a person who has basal segments involved, but apex is spared, this does not obey a coronary territory. Similarly, if you have a person who has basal anterior septum involved and basal septum involved, and the rest of the things are not, this also does not obey the laws of coronary distribution. So if we are knowledgeable of the coronary segments and we do understand a proximal lesion would cause the distal most to suffer the maximum and then the proximal portion also, we can not only rank coronary artery disease, which one coronary artery, one or two or three, and also whether it is proximal or distal. So sometimes what can happen is the wall motion abnormalities can also be quantified. And how do they quantify? Is now we are talking about not the magnitude, but the severity of wall motion abnormality. A normal contractility is one when the diastolic thickness increases by 50% during systole or more. That means if the systolic thickness is more than 50% increased from the diastolic thickness, this is normal. So the ratio is going to be 1.5. Hypokinesis is when the contractility is there, but it is not normal. That means less than 50% thickening, but more than 20%. Why? Because less than 20% thickening, our eyes cannot figure out. We cannot figure out the change of less than 20% in the thickness with our naked eye. And that is why it appears akinetic. That means there is no thickening. And dyskinesis is when instead in systole, instead of thickening, the segment becomes thinner, just like what I showed you in the first example. And what is important is when there is scar, this scar means there is outpouching of the shape of the ventricle even in diastole. So what happens is in simple dyskinesis without aneurysm, this diastolic shape of the ventricle is maintained. And in systole, it becomes going out and thinned out. Whereas aneurysm means there is an outpouching even in diastole and it worsens during systole. So that is what is the difference between dyskinesis and aneurysm. And we can also give them a score 1, 2, 3, 4, 5 in that particular order. Now we have 16 segments, and each segment would have a score of 1 to 5, right? If every segment is normal, the total score of 16 segments would be 16 times 1. This is 16. And if we divide the total number of score by the number of segments assessed, it would be 16 divided by 16, which would mean the score index would be 1. So if we have a score index of 1, that means the ventricle is completely normal. The higher the score index, that means if it is 1.5 or 2, that means that much higher wall motion abnormality. Either the number of segments are higher, or the akinesis or dyskinesis, which is higher in score, is higher. So any which ways, the higher the index, the worse is the outcome, and much worse is the ventricular function. So whenever we do a wall motion analysis, we should not only comment on whether wall motion abnormality is present or absent. We should comment on the severity, whether it is hypo, normokinesis, akinesis, hypokinesis, dyskinesis, aneurysm. Scarring is something which we have to learn to pick up. Whenever there is scar, that means the muscle tissue is replaced by fibrous tissue. And we do know the muscle tissue has more water or more fluid as compared to the fibrous tissue, which would mean the ultrasound beam would rank muscle tissue as a little black and white, whereas the fibrous tissue would be more white and refrigerated. So a more white or calcified tissue is scarred, and this means this is unlikely to recover even if revascularization is done. The third thing is that we should also be commenting on which artery, whether it is LAD territory, circumflex, or the RCA, whether it is one vessel or multiple, and also is it proximal or distal, because all these factors do have a connotation of prognosis. Let's share some examples. This is a parasternal long axis view. I mean, you'll have to agree with whatever I'm saying and then probably build on whatever you have. In parasternal long axis view, this particular segment where my arrow is basal anterior septum. It's not basal septum, it is basal anterior septum. So first thing, in parasternal long axis view, we look at anterior septum, basal and mid. And then we have basal and mid posterior wall. If you look at the contractility in this particular patient, the basal and mid anterior septum are contracting well, and basal and mid posterior wall are not contracting at all, rather they are thinned out. What does it mean? These are akinetic segments in the basal segments, which means which artery? Posterior wall is distal circumflex territory. What should you do now is try to correlate in other views with the different arterial territories. So when we go to the from parasternal long axis view to apical four-chamber view, we start seeing basal septum, which is RCA, PDA that is, mid septum, which is PDA again, apical septum, which is LAD. Apical lateral, again, LAD. Sometimes there may be a superimposition from the circumflex territory. So what we find is basal and mid septum are normal. That means PDA territory is functioning okay. Apical septum and apical lateral also are okay. That means LAD, at least apical segments are okay. But what we find is the lateral wall, which is thinned out as well as akinetic. There is no thickening, which I can see here. Let's look at the third view. This is the two-chamber view. I cannot see the right ventricle here. This is the inferior wall, basal, mid, and apical inferior, absolutely normal. So that means the RCA is not involved in this particular patient. And basal and mid anterior wall and apical anterior wall also is normal. So in this particular patient, what we can safely conclude is the LED territory is not hypokinetic or akinetic, it's normal. RCA territory is normal. Circumflex territory is involved, and because lateral as well as posterior wall, both segments are involved, it is a proximal circumflex territory infarct. And this is all scarred and thinned out. It's unlikely to be viable. And this person is somebody who has had sustained dense circumflex territory infarct. Let's look at this case. Again, another parasternal long axis view, the basal and mid posterior contracting decently well, but contrast to the previous image, the basal and mid anterior septum is at best hypokinetic, although thinned out, but it's still contracting a little bit hypokinetic, which means LAD. This territory is LAD. And where in the LAD? I told you the basal anterior septum is supplied by the first septal branch. That means LAD, and LAD should be a proximal LAD lesion. So I have to also communicate there are certain fallacies we always look at, and that is because of the fact that is a two-dimensional image we are looking at, and the heart has a three-dimensional motion. It is not only contracting, it is also shortening in the length and also writhing movement is there. So what happens is I have to ask you a few questions, and you have to just understand what I'm trying to say here. This is a parasternal long axis view, the basal anterior septum, mid anterior septum. Let's forget the posterior wall for now. If I ask you what is the movement of the mid anterior septum, is it akinetic, hypokinetic, or dyskinetic? We can definitely perceive some kind of inward movement of the mid anterior septum. But if you focus on the thickness change, there is no thickness change. So, although there was inward movement, but there's no thickness change, and that is because this basal anterior septum is hyperkinetic and pulling the adjacent segment along with that. And this kind of situation, when there is movement but no thickening, still would mean that this is a sign of non-viability or infarction, right? So this area which is not thickening is less likely to be viable as compared to if it was showing some element of thickening. And this can so very well happen when there is a hypercontractile segment, whether it is increased heart rate or with passive motion. On the contrary, left bundle branch block is a very common thing where you can have spurious septum to be ranked as hypokinetic. Whereas because septum is contracting in a different phase, you can see the thickening of the septum is still there, but because it is happening in different phase, it gives a paradoxical motion kind of a thing, and people can rank as hypokinesia of the septum very commonly, specifically when there is thickening, but we are just focused on the movement because this happens in left bundle branch block, in right ventricular pacing, and WPWs. One more tip. If you look at the common understanding of this particular parasternal long axis view, let's focus on the back side. This is basal and posterior wall, and this very commonly would be the mid posterior wall. Similarly, this is the four-chamber view, and this segment would be septum, basal, mid, and apical, and basal, mid, and apical lateral wall. But mind it, one thing is very clear here. In this particular view, you can see the opening of the aortic valve. This is the five-chamber view. And aorta is an anterior structure. So that means this adjacent septal area is anterior septum and not the basal septum. If we had an RCA disease and in the LAD disease, this could be easily missed out and wrong interpretation can be done. Similarly, as I very clearly mentioned, parasternal long axis view gives rise to the posterior wall, not the inferior wall, and papillary muscle origin is from the inferior wall, not the posterior wall. So these kind of distortions do happen during diastole and systole, and we have to be very cautious what segments are we assessing in diastole and systole. Otherwise, we keep on going to make mistakes and wrong interpretations. The last part of the wall motion before I go to the short axis probably have some question and answers. This is a four-chamber view. You look at the basal anterior septum, basal septum, mid septum, and apical septum. Basal and mid septum are okay, normal, and apical septum is hypokinetic. Basal, mid, and apical lateral seems to be absolutely okay, right? And the ejection fraction in this particular patient is going to be easily 45, if not more. So compare it with a different four-chamber view. In here, this is again a four-chamber view. Here, just like this, RA, RV, LA, LV, RA, RV, LA, LV. And the basal septum is normal. Mid septum is definitely almost akinetic here. Apical septum is akinetic. Apical lateral is akinetic. Mid lateral is hypokinetic, and basal lateral is normal. So these three components being normal, rest of them almost akinetic. Ejection fraction is down to 20, not more than 20, 25, right? So this is how the ventricular assessments is different. But you would be more than surprised to understand that both these views, one where we called 45% with a minimal amount of wall motion normality, and one we called as maximally injured ventricle 2025 with maximal amount of wall motion normality, almost completely LED gone, they are both from the same patient, just 5 or 10 seconds apart, just 5 or 10 seconds apart. There's no way the ventricle could have improved, deteriorated this much in 5, 10 seconds. No way the ventricle could have improved from this to this much in 5, 10 seconds. And this is what we call as the fallacy of foreshortening. Why it so happened is if you look at the two-chamber view, the apex is not even the picture in this particular view, on the left side. So the transducer was positioned here and the ventricle is being cut here. The apex, which is somewhere here, is not in the picture. And that is what we call as a foreshortening. And very common mistake by a novice who has just started to take the transducer in the hand. They put the transducer on the passenger long axis view and take the transducer all to the apex. And they are so happy, okay, I've made the four chamber view. They start evaluating that point. But you have to understand the apex is the outermost and downmost structure. So keep on going out and down till you lose the heart and then come in. You would not commit such a mistake. Otherwise, you'll keep on making 20% ejection fraction to 45% without any surgery, without any intervention, and you'll become God. One more thing, uh, about 10% of the people who come to us would have non-analyzable segments. Here you can see a dense calcification. I was talking to you about scar. This is a dense scar and some calcification because of which nothing here is seen. Endocardium is not seen. And same way, if you look at this ventricle, the septum, maybe there could be some endocardium seen, but there's nothing seen on the lateral wall. And so please don't rank this person for wall motion abnormalities until unless you see more than 70% of the endocardium. And you should be refraining yourself from saying anything. And why I'm saying is have a courage to report could not be visualized because something else could then be done rather than reporting wrong. So this was a little bit about the concept of wall motion abnormality and how to identify the segments, how to recognize the coronary distribution, how many coronaries rank the severity of the disease, and the holistic picture, wholesome report should incorporate all these aspects when you report wall motion abnormalities. So, a word about acute coronary syndrome. In acute coronary syndrome, because the injury has been done immediately, the wall motion abnormality cannot differentiate between established infarction vis-a-vis ongoing ischemia. So the decision of thrombolysis is never going to be based on the wall motion abnormalities. You can decide about in a person with ongoing chest pain to go for the cath lab, but the decision to thrombolize is always going to be on the basis of the ECG ST elevation and not on the basis of wall motion abnormality. Hurriedly, I'll go through the other do the Ticolo's method of assessment, Simpson's and modified Simpson's method, especially the plane view, is the best way to look at all these cumulative disk assessments to get us the volumes, diastolic and systolic, and calculate the ejection fraction, just like in this particular method. But unfortunately, a peculiar peculiar nature. And those pixels actually are just like fingerprints, which are unique. Today, the artificial intelligence imbibed into the machines actually can pixelate and identify the relative change in motion of all those pixels, based on which they can calculate the relative change in distance between the two pixels, and by way of which they can track the relative lengthening or shortening. When there is a ventricular contraction, the circumference of the ventricle comes down, reduces. So there is circumferential shortening. The length of the ventricle also comes down. That means longitudinal shortening. But the thickness of the muscle, the radius of the muscle mass actually increases because it is in the systole, it increases. So there is radial thickening. So radial strain, if you look at the strain, this is the relative change in the length or distance. So in longitudinal strain with systole, it would shorten. That means it would minus 20 is the right figure. If we talk about circumferential change, it is again shortened. So the circumference of the ventricle also would shorten. So strain would be negative, and the radial thickness would increase. So the radial strain would be increased in positive value. So these are things which have now been utilized, and you look at today, what we can do is we can pixelate, and the machine can give you on-time drawal of curve or various segments in diastole and systole, and we can actually calculate the regional ejection fractions and regional wall motion abnormalities much better than just looking at by eyeballing. So this is something which is being done, and just like what I was mentioning about the bullseye plot, today's machine can actually give you minus 20, minus 20, minus 20 in all these apical segments. One are okay. The light pink ones are lesser, and these ones are much lesser. So this is something which we can obtain by longitudinal strain analyses, and this can help us in assessing the wall motion abnormalities, giving regional ejection fractions, and can be reproducible, much better reproducible as compared to the eyeballing itself. So I'll end my talk here and probably go for questions if you have, so that we can initiate some discussions.
Thank you, Sanjay. Great talk, as usual. More than 25 years of existence.
Yeah, I lost all the hair while we were talking.
In last 25 years. And whatever left there become white.
Yeah.
So please go ahead and ask your question. You can raise your hand in the chat box so that I'll call your name one by one. Any questions, anybody? It's perfect. The talk is so simple that everybody is able to understand it.
Or otherwise.
Yeah. Yeah. Dr. Kasim Ali, go ahead.
Sir, good evening, sir.
Good evening.
Sir, when we called, sir, myocardium is thin, मतलब sir उसकी thickness वो defined है क्या sir? Thickness.
Yes,
sir.
yes, yes.
Yes.
You know, normal thickness is about 8 millimeters, plus minus a couple of millimeters. If it is more than 1 centimeter in ladies and 1.1 in men, it is hypertrophy.
Yes,
But
sir. Yes,
anything
sir.
below 6 millimeters is definitely thinned out. 6 to 8 millimeters is a gray zone. I mean,
Yes, sir. Yes,
different from that.
yes, sir. Thank you so much.
I see
Can I have
in
Dr.
the
Tajinder come? Dr. Tajinder, unmute yourself and go ahead. Yeah.
Good evening, sir.
good evening.
Sir, can you explain again how to score, how to do scoring?
Okay. So, I think what is important is two components. First component is that you have chosen the 16 segment scoring system. That means you are going to score all the 16 segments, right? Second
Sir.
component is each segment has to be looked at the severity of wall motion abnormality. And as I said, if it is normal contracting, the number given is 1. And the higher, more severe the wall motion abnormality, hypokinesis would be 2, akinesis would be 3, dyskinesis would be 4, and aneurysm, if you have diastolic outpouching, it would be 5. So higher the number, more severe is the segmental abnormal motion. So each segment would be required to be scored similarly. So, for example, out of the LAD territories, the apical 4 segments are akinetic, rest of the segments are normal. So out of those, the apical septum, apical anterior, apical lateral, and apical inferior, the 4 segments are then ranked as 3 each. So 3 times 4 would be 12, and rest of the segments are 12. That means 12 times 1 would be 12, right? So the total 16 segments would mean that the normal contracting 12 segments are 12, ranking the total score of 12. And the akinetic 4 segments are also ranking the total cumulative value of 12. The total score would be 24. And how many segments did we totally analyze? 16. So the total score index would be 24 divided by 16. This would be 1.5.
Yes, sir.
Right? So higher the
Okay.
score, higher is the severity. If it was 5 segments with akinesia, it would increase to 1.6. So that is how we have to understand whether it is the number of segments with wall motion abnormalities or this more severe type of wall motion abnormalities. Either which ways, the score index would be higher, and the higher the score index has a worse outcome, worse prognosis.
Okay, sir. Thank you, sir.
Can we have Dr. Shamina Sultana?
Assalamu alaikum, sir.
Walaikum.
Sir, kindly repeat the difference between dyskinesia and aneurysm.
Okay. I give you a combination of the two also is possible, but usually what we have to understand, the dyskinesia is a motility problem. That means the systolic architecture or bullet-shaped ventricle shape in systole would be preserved, but in diastole, in the diastole, the shape would be preserved, but when the ventricle contracts, for example, the apical segments are akinetic in the four-chamber view, and this is the apex. This is the apex. What would happen is when the ventricle contracts, the apical segments would thin out and outpouch. So this ventricle is normal, and this would be outpouching, where thinning as well as outpouching. This is dyskinesis. This means the kinesis should have been in one particular direction, rather it is in the opposite direction. On the other hand, what happens in aneurysm is the ventricle muscle is so far gone that there is no muscle remaining, and it's all fibrous tissue. And the fibrous tissue has, instead of being like this, has become deformed even in systole, even in diastole. So there is an outpouching. That means the ventricular pressure has led to ballooning out of the ventricle, which leads to a deformity even in diastole. And this becomes worsened when the left ventricular pressure increases during systole. So if the diastolic shape is maintained, it's only altered in systole. This we call as dyskinesia. On the other hand, if the diastole also has shown an outpouching, this is a aneurysm. You get it?
Okay, sir. Okay, sir. Thank you, sir.
Can we have Dr. Ravi Kumar Nirmala?
Sir, good evening, sir. Sir,
evening.
I would like to know regarding hypokinesia, is there an objective way to say that, or is it like if when I am doing an echo, especially with higher heart rates, like 100, for example, 90 to 100, sometimes I feel that a particular segment is hypokinetic. And when someone else does it, then they say it is normal. So how do we resolve this issue, sir?
That's excellent question. There would be times when even Dr. Rakesh Gupta and me, we can falter, but I give you certain tips. Point number one is that 20% to 50% assessment is all theoretical. I mean, you are not going to measure the thickness of each segment diastole and systole. The practical tip is if there is a perceptible thickness, that means in diastole and systole, when you're watching the segment change in diastole and systole, you can see the perceptible thickening is still there. Just like the example I showed you. When there was anterior wall MI in the Paston Longs view, I showed you there was the posterior wall which was thickening much bigger. The thickness increase was much bigger as compared to the septum, right?
Yes, sir.
So, what we usually do in our clinical practice, we look at certain normal segments.
Okay.
And mind it, when we have infarction, the normal segments, the surviving segments, would become compensatorily hyperkinetic. Hyperkinetic means they would become, their thickening would be much more than 50%. So what we do is that we look at the certain segments in the 16 segments which are hypercontractile or normal. That is normal. And compare the change in thickness in the segment in question against these so-called normal segments. So if the thickening in that particular questionable segment is less as compared to the normal segments, this is hypokinesia.
Thank
Do
you,
you
sir.
get my point?
Yes, sir. Yes, sir. I
Right.
get it.
The problem comes when each segment, all the areas are globally equally contracting, right?
Awesome.
So in that situation, the problem does come. But this is where your balding and your graying is important, because then you can go back to your memory lane. This ejection fraction is not normal. That means although every segment is contracting well, this is not normal for this particular heart rate.
So, do you have any video for that just to see?
Not as of now, but obviously in my compendium, I have a lot of people, especially when you go to the stress echocardiogram, you can imagine when the person has exercised, the heart rate is about 130, 140, the heart is contracting like that. You have to train your eyes at rest as well as on exercise to understand which segment has done pretty well, which segment has not. So once you do a stress test and dobutamine and all those things, all those ideas do come to your mind.
Thank you, sir. Noted.
Dr. Muzaffar Ahmed?
Good evening, sir.
Good evening.
Sir, can you explain again the fallacy of foreshortening?
All right. So I did give that example, and that is pretty well documented one. You could see the images, if you can recollect, when I was showing the four-chamber view on the, which was displayed on the left side of the screen. The contractile ejection fraction was coming out to be 45%. On the right side of the screen, it was just 20, 25%. And both the things were just done such that when I put the transducer, this is how you start, right? Personal law axis. And when you have completed your personal law axis view, you try to go out and down, slide your transducer and go and start seeing the four chamber. Most of us actually have a wrong habit of being so happy that, I've seen the four chamber view, and you start doing your calculations then. But this is wrong. You should keep on going out and down till the time you lose the ventricle. And then you come in a little bit and get the good four chamber view. Otherwise, sometimes about 30 to 40% of times it can so happen that I can make a foreshortened long axis view in any given person.
Thank you, sir.
All right, anybody else? Some other questions?
Good evening, sir.
Go ahead, Dr. Kamal.
Sir, if we had not a proper view like foreshortening, then definitely we will mistake in calculating the dyskinesia or akinesia, like things.
Absolutely. But what happens is if you are vigilant enough and learn to look at all the views, even the short axis view, when you have a pattern long axis here, and you rotate the transducer for a short axis view, you should look at all the segments, the basal, mid, and apical segments. This particular view itself, you'll have a fair amount of idea what you're looking at. And whenever you go to the apical views, then you look at the two chamber views, three chamber views, you'll have you have to make one very clear concept in your mind. The benefit of doubt should go to the patient, right? If you have to make errors towards the safety rather than otherwise. So if you have a confusion in a particular view, look at other views and just make sure that what your assessment was right or wrong.
Thank you, sir.
Anybody else would like to have some questions? Or I think everybody has learned a lot about segmental wall motion abnormalities, hypokinesis, akinesis, or dyskinesis. And all credit goes to Dr. Sanjay Mittal for excellent explaining all those important things. And one thing I always say, please calculate your ejection fraction in modified Simpson's biplane method once you are beginners. When you become expert like Dr. Sanjay, then you can do eyeballing, but don't do the reverse right now.
Yes. Yes.
So that's what our take-home message would be all the times. And with this, we can say thanks to Dr. Sanjay Mittal for excellent deliberations. We'll break over here, and Sanjay, I'll stop recording. You can disconnect anytime because I'll take the attendance now.
Yeah, sure. Okay. Thank you, Dr. Rakesh. Thanks, everybody. Bye-bye.
Thank you, everybody. Thank you, Dr. Sanjay Mittal. Thanks a lot.